Good morning, everybody. My name is Diana Sousa. I'm a stroke neurologist working in Lisbon and the chair of the ISO Young Stroke Physicians and Researchers Committee. And I have the great pleasure of interviewing today Jamie Verhoeven from Nijmegen, the Netherlands, who is a PhD student at Radboud University and coordinating investigator of a nationwide Dutch study assessing the incidence of cancer in patients with stroke, which was just presented at this conference. Jamie, congratulations to you, your supervisors, Frank-Erik de Looij and Karin Klein, and all the team for completing this important study in which you address a common clinical question for physicians managing patients with acute stroke, which is whether stroke may be indeed a first manifestation of occult cancer, especially when you don't find any possible etiology. So to begin with, could you please give us a short summary of the background of this study?
Yeah, so first of all, thank you very much for having me and also giving me the opportunity to highlight our study at this very nice platform. So the important question you raised, the important clinical question you raised is that in a lot of cases in young stroke patients, we don't find the underlying cause. So we don't actually know why they have their stroke at such a young age. And well, we know that in venous thrombosis, there is an association with an underlying cancer. And actually, we did a study a few years ago on the mortality risk in young stroke patients, so a little bit of a different subject. But we found that cancer was actually the second most common cause of death in these young stroke patients, which quite surprised us at first. And then we started thinking about, well, could it actually be associated? Could maybe the stroke be related to the cancer that might have already been there? Exactly the same actually as for venous thrombosis. And there is some literature already on this association, but it's mainly smaller sample sizes, and it's not always, the risk is not always compared to the general population, which is, I think, in this kind of research very important. Mm-hmm. So we set up a large study. So it's a population-based observational cohort study using nationwide administrative databases from the hospitals in the Netherlands. And these registries span 20 years. So we have data from 1998 to 2019. So up until the end of 2018. And we were able to identify patients with an ischemic stroke or an intracerebral hemorrhage in these registries and follow them over time.
Thank you for this comprehensive overview of the background of this study. And so now we are really very interested in knowing the results of this study. So can you tell us a bit about the final results?
So yeah, of course, I can comment on the results of our study. I could actually talk for hours on these results, but the main findings that we had, well, first of all, a very large sample size, so over 27,000 young stroke patients and over 360,000 older stroke patients. So older in this case is defined as 50 years or older. And we looked first at the cumulative incidence of cancer after a stroke diagnosis, so both for ischemic stroke as for intracerebral hemorrhage patients. And we found that the cumulative incidence actually increases with age, and it also increases over time. Whereas when you compare these risks of cancer to matched peers from the general population, so we matched them based on age, sex, and also calendar year, we found that it actually, the effect inverses. So the risk increase compared to peers from the general population is much higher in the younger patients. And it also is highest in the first few years after stroke. So the risk increase is highest in the beginning after the stroke, and then it decreases over time, which clearly shows a temporal association between these two events. And what is interesting is that we found a high cumulative risk in the young patients for breast cancer. So also the cumulative risk was a lot higher for younger women with stroke compared to younger men with stroke. Whether when you compared this to the general population, so the matched peers, this difference completely disappeared, and actually men became a little more at risk. It was not significant, but the trend was there. And when you look at the different types of cancer, for the risk increase, this is not the case for breast cancer. So the risk in the stroke population is actually the same as in the general population. So it's quite nice to look at these different graphs to see whether there is a true effect.
So these are really surprising findings. However, in the results you presented at the plenary session, we could see that the median follow-up was shorter for ICH patients. So do you have an explanation for that? And how much do you think does that impact on the reliability of the estimates for patients with ICH in this study?
Yeah, I think that's a very good question and an important point also to discuss. We found that even for ischemic stroke, the follow-up duration differed between the younger and older patients, where the younger patients had a longer follow-up time than the older patients. And in both age groups, the follow-up for intracerebral hemorrhage was much shorter than for after ischemic stroke. And this could be almost fully explained, or possibly even fully explained, by the increased risk of mortality in these groups. So we looked at why the follow-up ended. So this could be either death or loss to follow-up because their identification code changed, or when they emigrated, for example. And we saw that a lot of these patients with intracerebral hemorrhage, especially at older ages, they have just a very high mortality risk. So then you lose them in the follow-up for looking at other events. So this is also why we corrected the cumulative incidence for a death as a competing risk, and not just use a Kaplan-Meier analysis, which is more common in these kind of curves. Because if you do not correct for the risk of death, it may lead to an overestimation of your effect. So we corrected already for this. I think another important point is that when you have an intracerebral hemorrhage and you have like a case fatality, so you die rather quickly, then the diagnostic workup is not always complete. So this might also lead to an underestimation of the effect. So it makes it a little bit less reliable, but I think the effect is still there. It's a true effect.
That is very useful to know. Thank you for the detailed explanation. So since this study was based, as you said, on administrative data, we know that detailed clinical information should be mostly missing, which is of course a limitation. Still, I have to ask, do you have any data on the specific features of ischemic stroke in patients with occult cancer or ICH? For example, presence of multiple simultaneous infarcts, the pattern of the infarction in patients with ischemic stroke, how often these patients have, for example, very high D-dimers. Are there any specific features that can guide us in finding these patients?
Yeah, so unfortunately, these administrative databases that we use do not contain any clinical information on the patients. So we really only knew their age, we knew their sex and like the discharge code, so ischemic stroke or intracerebral hemorrhage, but there was no more detail than this. So that really limits also the interpretation of the results of this particular study. There is quite some literature, so high D-dimers and also the affected, multiple territories affected or a recurrent stroke within a short period of time seem to be associated with a higher risk of having an underlying cancer. And currently in Nijmegen, we are working on this. So we have 2 large clinical data sets of young stroke patients that are actually quite extensively phenotyped. So we are looking into which patient characteristics and which risk factors are actually associated to find whether there are certain groups of young stroke patients that are more at risk of having an underlying cancer. And we hope, of course, or we expect, I should say, that these will be the patients with a cryptogenic stroke and probably less cardiovascular risk factors than the other younger stroke patients. But that is still purely a hypothesis and not proven.
So that is great to know that you and your team are planning these follow-up studies and that we will know more about this in the near future. So finally, and probably the question everybody wants to ask, is what to do when translating these results to clinical practice now. So I know the study was not designed for that purpose, but still considering these findings, what would you recommend to clinicians concerning the diagnostic workup in especially young stroke patients, particularly screening for an underlying occult cancer?
Yeah, I think exactly as you say, so this study was not designed to investigate like a causal relationship, and it's probably too soon to really give real clinical advice in a systemic way, or like what you should always do. But I think research is really needed to see whether this could be an option. So I can imagine that if we have more studies and we can reproduce these results, that there may be a place for cancer screening in the diagnostic workup, probably, especially if young stroke patients, probably in the cryptogenic group. I know that in our center, because we have been working with this research for quite some time, that if there's a young patient who has like recurrent strokes, mainly when they also have venous thrombosis, and really no other clear cause can be found, that we sometimes look for an underlying cancer. And in anecdotal cases, we found an underlying cancer, but this is, well, purely anecdotal, and this is in our center, so I would not systemically recommend this, but it's maybe something that you can keep in the back of your mind when you really don't know.
So fantastic. Thank you very much again for conducting the studying and sharing this unpublished results with us upfront at ESOC. And again, congratulations to you and your team. And we really look forward to hearing from you on the next steps on this field in the near future. Thank you very much.